important to advancing equity is, one, making sure we make injustice visible, as well as recognize and honor the experience and expertise of those who have experienced injustice. And so I think it's absolutely right and dutiful to honor and recognize the indigenous people who have been on this land for over 12,000 years, who have survived years of being tried to be made invisible, as well as vanished from this space in this land called San Diego. So I just want to make sure that I honor and recognize the indigenous people. So this is me. This is my mother and I. This is Harrisburg, Pennsylvania. I am a daughter of an immigrant and a mother who was very keen to make sure that I was going to have better opportunities than she had in the island of Antigua, where she grew up. And she even at one point in time moved from New York to Pennsylvania to make sure that I could go to schools and good public schools at a lower and affordable cost, so that I could do whatever it is that I wanted to do, whether it was dance, piano, and she would be able to afford those opportunities. And so we moved into the suburbs of Harrisburg. And while schools were great, lots of activities, one of the trade-offs was I was one of the only Black students within my neighborhood, as well as within my school. It's not a unique story. There are many folks who are the only of whatever it could possibly be. But there is an experience that you have, and there is something potentially that you carry through with you for the rest of your life. In my experience growing up in that school system, I learned very much that if folks don't feel you should be there, if the institutions and the people in them feel like you shouldn't be there, they will do things to make sure that you are excluded from that space. And so my mother had to advocate many times, many years, was in school quite often, not because of my behavior or because I was a student that acted up, but there was a disbelief that I should be there. I was moved to lower reading group levels by the teachers, only be told by the tutor that my mom hired that Aletha has no problem with comprehension. She's just bored by the books that she's reading. To be in junior high school, and my mom having to push for me to be in the upper track, even though I had straight A's in school. In high school, her having to sign a letter that if I failed AP English, that it would not be the school's fault, it would be ours, and nobody else had to do that. And on my last day of high school, I actually sat in in-school suspension, which is a whole nother longer story, for being really equated to passing out materials in a similar way that skinheads would pass out materials in schools, which was very unfair and unjust at the time. And so I learned, again, that institutions can really dictate what happens to an individual if they do not want you there, but I also learned the potential and the capacity of what advocacy really means, not only on the part of parents, but on the part of communities. And it's really guided how I've done my work so far throughout my career. So I graduated from high school, went to one of the top universities for college, went off to med school, and then graduated and realized I didn't really fully want to practice medicine. I couldn't figure out what I wanted to do. I did finish my pediatric residency. I bought some time and decided to do preventive medicine, public health after that, because I really valued this lens of public health, the idea that folks actually do have a social context to their lives, and maybe we should be paying attention to it. And so I went that direction, and I was afforded a lot of great opportunities as it relates to public health within the government sector. Also a lot of opportunities as it relates to entrepreneurship within an institutional setting. So I've been a founding director of an Office of Minority Health in Suffolk County and Long Island. I was also the founding director and deputy commissioner of the Center for Health Equity in the New York City Department of Health, one of the largest health departments in the urban world. And now I'm here at the AMA as their inaugural Chief Health Equity Office to start this Center for Health Equity here. And also during my career, and if folks don't have little kids or little grandkids, you might not know who this is, but this is Doc McStuffins, one of Disney's top cartoons at one time. And I had the opportunity and pleasure to be on the cartoon. And while it's cute, it is cute. The important part of it, though, is that it also speaks to justice, because Jocelyn Elder says that if you can't see, you absolutely cannot believe that you can actually be in this place. And so my career I've lived it, my professional life says it, and I definitely try to speak that truth to power. So I'm here at the AMA, inaugural Chief Health Equity Officer. I've been in Chicago now for 7 months. I'm very new to the position. And Chicago is a city that, like other cities, has tremendous inequities. It's one of the cities that actually has the largest life expectancy gap between areas of the South Side and in Streeterville, where I actually live, and the gap is 30 years difference life expectancy, 30 years difference. And so all of the work that I do is not only rooted at the national level, but it's really also having this focus at the local level. So AMA is representing 210,000 physicians in terms of membership, and they're really working to support being the physician's powerful ally as it relates to patient care. So this is Jim Madera, who is the Executive Vice President and CEO, and it was announced this year at our annual meeting that we would be launching this Center for Health Equity, and that we were going to demonstrate true commitment to this process. Now, doing equity work, I have a lot of folks who come up to me quite frequently with lots of honesty and authenticity about their image and their views potentially of AMA historically. While definitely a powerful organization, has had a lot of voice and presence in space of advocacy in DC, but we know that the history is complicated, as many institutions are in this country. And the AMA, from my experience, is definitely an evolving and changing organization. We are at an historic time. Not only is there the Center for Health Equity, but we're at a time where we have 3 women presidents. We have the immediate past president, Dr. Barbara McAnee. We have the current president, Dr. Patrice Harris, who's also the first Black female president of the AMA. And then Dr. Susan Bailey, who is the president-elect coming up. And so it's an exciting time that not only are we living or speaking the commitment, we're also living that commitment. And so my role is to figure out, so how do we embed health equity across the entire enterprise of the American Medical Association in terms of actions and policies, performance measures, innovation. And so moving to that direction means we have to all understand what in the world health equity means. And so this is one of the definitions that I use in terms of the outcome aspect of it. Having the conditions, resources, opportunities, and power to achieve optimal health. And you need to have all of those. We all need to have all of those in order to achieve optimal health. And these are, the graphic is pretty self-explanatory in terms of these differences and distinctions between equality and equity. And I think what's really important to also point out is how normalized inequity can actually be embedded in things like pictures that we look at. Because as my millennial students will tell me, that this picture does not represent the spectrum of gender identity. And it can be actually triggering for some folks. So this work means that if we're talking about folks understanding health equity from an employee standpoint, that we're also speaking about systems thinking, but also disrupting and doing things differently, changing mental models and assumptions about how we show up in this work and how we view people are connected and affected by our work as well. And so the whole strategy is an inside-outside strategy. Folks, when I came on board, and I'll hear this, like, so what am I doing on the outside? What are we going to do as the AMA with other people? And I said, well, really the power comes when we internally can look inside, ask ourselves those critical questions of what are we doing, how are we connecting, how are we understanding, how does equity show up in our decision making, actually will more so impact what we're doing on the outside. So we have to look at our leadership commitment and our workforce equity and how we're communicating with people, who's at the table when we do and who's not at the table when we look at innovation around precision medicine or digital health or augmented intelligence. All of this, the theory is that it will inform how we do our programmatic work, our policy work, research and evaluation. And this is the model that I used when I was at the New York City Department of Health. So this is a national best practice. And what we're implementing and what we're doing is, one, normalizing, organizing, and operationalizing. So normalizing is about building a shared language. One of the challenges with talking about equity, justice, racism, gender oppression is that we don't have a shared understanding of, one, the history, the language, and the knowledge as it relates to any of these areas. And so we have to work institutionally to make sure that we are all on the same page and to kind of build that capacity. And so a large part of that is an aspect of training and an aspect of bringing folks into the space to kind of share their expertise as it relates at the intersection of anything in equity. Organize. What are the champions? Who are the champions, rather? And how are they able to amplify the work across the institution and also offer accountability? and operationalizing. What are those tools that people actually need in front of them on a day-to-day basis to change the decisions that they are making? So I just want to go through normalizing a little bit more deeply. So I've been in public health, so I have been to the left side of this chart, the 80% of what we say really creates health for the most of my working career, trying to convince the 20% on the healthcare side that they need to pay attention to this 80%. So now I'm on the 20%, trying to work with the 20% to integrate what's happening at the 80%. So it offers for me a really great opportunity, I think, to work on how do we merge the two. Another opportunity that we actually have to do as we do this work is really understand our biases that we all have within this world. They help us make decisions. They help us make decisions around staying away from danger, but they also can create danger and cause harm. And we need to be aware of that for when it happens. But we especially need to pay attention to these particular factors related to race, gender, sexual orientation, language, culture, ability, physical ability, meaning mostly, and age. But I also challenge us that things such as race is not necessarily a risk factor. It's the system that's around it that actually created it. Racism is the risk factor. And that we have to look more so at the institutions that produce risk that people have to live in. And so that changes how we go about solutions. It changes how we go about who needs to be at the table in order to create solutions. We also have to recognize and honor our power and our privilege. There's clearly racial equity, or racial privilege and power, but there's privilege in us being a medical institution and us being physicians. People listen to us. We have a lot of power, and we need to use that power well and wisely. It's important, the historical context. How did we get here? I heard earlier somebody mention about policies and advocacy and the importance of policies. Policies have changed and determined where people can live, what they can eat, everything that we do really in this country. And they have also removed people from land, and they've also forcibly brought people over here from other lands. And so we have to understand that that really creates a lens of how we do a lot in this country. And in terms of time frame, if you look on the graph on the right, done by a Baltimore artist, we are really very much in this new period of American history. We've been 13 generations of legalized slavery, 4 generations of legalized segregation, and only about 2 generations of really being legally free. So the majority of our country, the majority of Americans, have only been in this small part of this legally free area. Most of our history has been under the guise of slavery and segregation. And to bring it to a global context, and really a deep root of where inequities and injustice lie globally that affect many countries, is really making sure that we look at the root of the impact of colonization. And this was done by a doctor who's actually here in California at UCFS. And it really speaks to this root cause and this understanding that in order to better understand how we get to health equity and address health equity, we have to understand what are those inputs. Those inputs as it relates to labor, those inputs as it relates to land, and then see how it goes down the pipeline to actually cause trauma. We have to learn that inequities are produced, and then we also have to learn that there are dominant narratives that also exist, that also impact how we are understanding the world and the world that we live in. And these really undermine our ability to do health equity in a very good and reasonable way. We tend to see people as unfortunate, and that they're just lazy, and that their lifestyles, and they should really be blamed for the health that they have. And so we've been starting a lot of efforts to organize around this work. We've been having health equity sessions and learning sessions. We actually had our first racial equity training session, where folks actually had to participate. We're sending out resources and starting a resource center. We're organizing so that we have accountability and an infrastructure to that. And we have a health equity work group. And we're putting tools and critical questions. If there's anything to take away from this, it's this slide right here, are these critical questions that you all can ask yourself as you're developing, you're thinking, you're partnering. These are the questions to ask. Who's burdened? What are the unintended consequences? And from here, the other important aspect is leadership and how you are going to show up. This isn't about good intention or bad intention. It's about what is the impact. And is that impact going to improve health? Is it going to close the gaps? And are you not going to create further harm? And so we have been working to figure out how to do that best. We've been working in terms of the medical education space and making sure we provide more around social determinants of health and structural determinants of health. And our leader, Jim Madera, announced the other day that he's recommending that all senior leaders, vice presidents and above, actually take the Racial Equity Institute training. And so to end out, I think what's also important and another aspect of equity that folks don't typically talk about is, again, this harm piece and how do we heal from this. Many may recognize one that's a spectrum. It was an invention done in the mid-1800s by Dr. J. Marion Sims, considered the father of obstetrics. However, we are also very clear that a lot of experimentation was done on women who were enslaved and done without anesthesia, up to 30 times operating. And we know all of this because he actually wrote it in his biography. It's there to, his autobiography rather, it's there to kind of read. And so we have to talk about the harms and how do we fully recognize and reckon with the impact of these harms. This is the apology from the American Medical Association, who excluded black physicians until civil rights was passed in the mid-60s. And we have more to do in that lens. And just to end with Sims, in terms of what has been done in New York City and what does healing look like and what does recognizing trauma look like. So the mayor put together a commission. It was recommended that the statue come down. And so that's me at the statue with Dr. Harriet Washington, who wrote Medical Apartheid, who really told that story that was really invisible to many. And this is us, hugging and being relieved that we didn't have to see that sight any longer. And as I end, I think what's really important is that we're not silent. Equity does not just happen. You have to be extremely intentional behind it. I can't tell people fully without just, I can share my story with you and we can share stories with each other. But if you are from a marginalized population, it's hard to really impart what that sense of urgency is. But I think it's absolutely critical that we are not silent and that we figure out what that voice is as individuals and institutions so that we can ensure that everyone does have the optimal resources and opportunities and power and conditions to have optimal health. Thank you.
Thank you. Mm-hmm. One quick question.
Yep.
Thank you so much for sharing that. Part of the theme of the last 4 days has certainly been technology and how that can improve access and democratize, but there's also a danger in terms of equity and sometimes technology if you're programming the AI agent the wrong way with the wrong data sets. Can you touch a little bit on that element? Because there's some recent publications.
Mm-hmm. So, right, danger from not only just the algorithm parts, but even the training sets that we know or the data sets that may not be fully complete or not, and we have that challenge in general, no matter where you are in kind of the health spectrum space. We have that challenge in public health. Is the data collected right? Is it aggregated right? Is it disaggregated right? And all of that feeds into the algorithms that are created. But I think that the step back from it is to say that these systems, they aren't, the challenge is that most folks think that these systems, are objective. And they aren't, right? They are all created by somebody in this room or people. And so our own biases get built into how these systems are created. And the reality also is that there is a lack of diversity within and among the folks who are having the opportunities to do innovation or to have their innovation be valued. My contact with communities of color or other marginalized neighborhoods in cities across the country is that there are a lot of folks who are innovating. They're in their own space. They understand the context of their neighborhoods. And they're not getting the same opportunities. I get the calls. So how do I get this? How do I get this? Bright people, great and connected to academic institutions. They may have actually already started something, but they're not getting the access and the exposure to venture in the way that other folks are getting it. So I think as people start to innovate, it's also thinking about who else needs to be at the table in all aspects of your planning and thinking about the end user not only as a patient, but also those who are experiencing the greatest burden of disease as well.
Great. Thank you, Dr. Maybank, for what you're doing for everybody.
Thank you.
Thank you.
Thank you.